Hello, welcome to my presentation of post-traumatic stress disorder. The client that I'll be focusing on is named Kelly. The client, Kelly, had presented with a disheveled appearance, along with having cuts and bruises on both of her arms. She came in also looking very unkempt. She was not up to discussing her problems and issues at the time. She was nervous, with both tapping her toes and biting her fingernails, which also signaled that she was anxious. Kelly did describe that she often has trouble sleeping and eating throughout the day, and she can also feel very panicky at times as well. Kelly came into the intake with symptoms of flat affect, negative mindset, feeling both anxious and overwhelmed, along with having flashbacks and moments of panic. Kelly is mainly seeking treatment help to both concentrate better on her coursework and help to get her grades from failing to passing. She also wants to look at what treatments can be used to help her symptoms better, since her current treatment does not work as well for her. Kelly expressed the statement that she did not want to talk about the trauma that happened in her life. Physician McNair concluded poly-victimization was a stronger correlate of PTSD than number of traumas or physical and sexual assault and abuse. Kelly also expressed that she feels guilt for her trauma and that her parents do not know about the trauma. She did experience a flashback where she said, "Get off me," and when she was asked, she avoided answering the question. Kelly also stated that she did not want to talk about the abuser and that she also hates the abuser. Kelly has had a strained relationship with her parents. She is the only child, and her parents have done drugs for most of Kelly's childhood. Kelly has a history of mental illness in the family, with an aunt who has bipolar disorder and an uncle who has depression and anxiety. She also has a cousin who was diagnosed with schizophrenia. Kelly was taken out of her parents' care for a period of 6 months when she was 10 years old due to a car accident that was caused by her parents, where they were arrested due to both their drug addictions to cocaine. Matthew Price concluded, network analysis identified 5 communities, one containing all depression and generalized anxiety disorder symptoms, and 4 for PTSD and symptoms of depression and generalized anxiety disorder, which are highly interrelated and that PTSD is heterogeneous. During Kelly's childhood, there were moments where Kelly was the one who had to take care of herself because her parents were too strung out on the drugs to care. Kelly was taken to live with her grandmother for a time, but then eventually was returned to live with her parents. Having Kelly be so traumatized by the accident, then taken to live with her grandparents, it had an effect on her mental health, and it did not help her anxiety. Kelly and her family are Italian, so that means that they have their own cultural perspectives on mental health. Some Italians see therapy as a waste of time. People in the culture would be skeptical of using mental health treatment because it can be seen as bringing up trauma that does not need to be said to strangers. When it comes to anything that is new or different, it is expected in the Italian culture to not see it as a good thing. And with abuse or trauma that can happen, it is to stay in the family. Also, having help from an outside source who may want there to be help, there may be pushback from the family due to relying on themselves and not on others. Karen Clemask concluded that students who report PTSD symptoms following childhood adversity perceive higher levels of stress. In terms of Kelly's social status, she is in the lower middle class because of the jobs that both her parents work and how much money she and they both would be making. Being in a lower class, it can be harder for her to have access to quality treatment because of how much money she makes. She may not be able to feel comfortable with talking about her issues with being a college student. Since she has had adverse childhood experiences, she may not be as likely to ask for help, which can be frustrating in that she has anxiety. Money would be an issue in having enough for treatment as well as other essential items. Jessica Bernardi concluded, cultural differences in self-understanding influences how individuals appraise experiences in terms of agency, control, mental defeat, and negative independent appraisals of self. Having an environment where there is a difference of opinions and where it is more difficult to have control for Kelly, it can be challenging for her to have her own thoughts with her family and environment. Kelly has strengths in standing up for others and standing up for what's right. She is not afraid to tell her opinion when defending someone. She knows where her priorities lie and knows how to lead and be a force to be reckoned with. She can be motivated with doing tasks and able to be determined. She can handle money really well in terms of her job performance and enjoys the aspect of what the value of a dollar can be for her and the strength she can gain in her future. Kelly enjoys making digital art, which can help her in her strengths of having coping skills to deal with her trauma. Kelly is able to be strong in knowing that she can overcome challenges. She can feel others' emotions very strongly and can also help others to handle and cope with their emotions. Marjorie Van Torenberg concluded PTSD severity and emotion regulation difficulties significantly decreased following trauma-focused treatment, and emotion regulation difficulties is not associated with worse trauma-focused treatment for PTSD. Kelly can also have the ability to be patient with others and understand when they may be in need of a break. Kelly has weaknesses, though. She has trouble communicating with others. She can often have trouble with both talking too fast and also stuttering when she does speak. When it comes to talking on the phone, it can be difficult for her due to having to talk to her parents while they were in jail when Kelly was a child. Kelly has missed calls from both her work and school about important events. Kelly has trouble with controlling her impulses, too. There will be times when she will make choices in her speech and then instantly regret what she says because she's not thinking through what she has said. She has trouble with the concept of health in that she will not go to bed at a regular time and be up late studying. She enjoys eating junk food, but occasionally will eat a healthy meal. Kelly can also have trouble with maintaining relationships in that she gets into them. She will only be in them after a few weeks, then dump the relationship because she does not want to be tied down. She is also unsure about her sexuality, which can also be issues in a relationship because she may not know what she likes. David Solomon concluded, internalized stigma, specifically homonegativity, only predicted PTSD symptoms for survivors of sexual trauma, and outness was not predictive for either group. The first assessment that was used with Kelly was the CAPS-5, which is an interview that has 30 items and can be used to make diagnoses over the lifetime of the week and over the last month. For Kelly, the version that would be used is the past month. The assessment has 7 different criteria for Kelly to go through: different experiences, memories, avoidance of feelings, remembering the event, alterations of emotions in both angry outbursts and concentrating on tasks, and asks about how long the symptoms have been going on as well. It's asking about how the symptoms have been with Kelly's relationships. In terms of scoring for the different criteria, it is broken down into categories and numbers. The first scores are scored by a severity scale of 0 to 4, with 0 as absent, 1 as mild, 2 as moderate, 3 as severe, and 4 extreme. Having those scores from 0 to 4, they go to a scoring in a symptom severity score, which is from 1 to 20. Criteria F and G must be met. Criteria F requires that the disturbance has lasted at least 1 month, and criteria G requires that the disturbance cause either clinically significant distress or functional impairment, as indicated by a rating of 2, which would equal moderate. Kelly would score in the mild, moderate, and extreme areas. She would score mild in remembering the trauma. She would score moderate in losing interest in activities. She would score extreme in blaming herself and having negative feelings. Jan Peter Spies concluded differences between all three groups in CAPS 5 sum and subcell scores. Internal consistency was calculated using structural equation modeling based internal consistency coefficients. Kelly has had her symptoms last for 4 years, and they have had a mild effect on her relationships. For this assessment, Kelly has given clear and valid answers, and there would be no reason as to why she would be faking. The second assessment that was conducted was the PTSD checklist for the DSM-5. Kelly would have to fill this out herself. There are 3 different criterion for this that can be used. The first is without criterion A. The second is with the brief criterion A that has 3 parts, and the third is the extended version of the assessment. For each part of the assessment, there are 20 questions to answer. The assessment goes through 3 parts. The first part of the assessment focuses on all traumatic events that can happen in a person's life. The questions go through each event that can happen, such as military events, rape, serious illness, violence, and threat of harm. The second part asks questions regarding the responses to Part 1 in terms of the trauma that was experienced and how many times the person had experienced the trauma. The third part of the assessment is split up into statements and responses. There are 20 statements about the traumatic event, and then with the responses, they are rated from 1 to 4 in the categories of little, moderate, quite a bit, and extreme. Madison Silverstein concluded that in terms of item discrimination, inability to experience positive emotions, detachment from others, diminished interest, and negative emotions emerged as highly discriminating. In Kelly's scoring for this assessment, she would score in the first part as having experienced trauma of sexual assault, witnessed an assault with a weapon, learned about human suffering, and left any injuries. For the second part, she would describe the trauma in detail of her sexual assault and put that it had happened 4 times with involving sexual violence. In the third part, she would put moderately for 6 statements, quite a bit for 9 statements, and extremely for only a few statements. The third assessment that is used is the PTSD scale, which is created by Edna Foa. The original scale had 17 questions. There are 24 questions in the updated version, with categories and 5 questions for each category. The symptoms are rated with a 0 to 5 rating scale, and seen as being present when a symptom is given a 1 or higher on the scale. The first part of the assessment is asking about screening for the trauma. The questions ask about traumatic events that were gone through, such as torture, a threatening illness, accidents, and combat, for example. The second part goes through 3 categories of questions that focuses on avoidance, cognitive changes, and reliving the experience. Each of the categories has about 10 questions. In terms of scoring for the assessment, it would be from 0 to 4. 0 would mean not at all, 1 means a little, 2 means a bit, 3 means very much, and 4 would mean severe. The scores would then be calculated and added up. For Kelly, in scoring, she would score a 2, a total of 3 times. She would score 3, a total of 5 times, and score a 1 only twice. Amanda Rains concluded that IU was significantly and robustly related to the avoidance cluster of PTSD. The suicide assessment used for Kelly was the Columbia Suicide Severity Rating Scale. The version used is the one that would be used in a crisis and is a risk assessment. It covers behaviors, attempts, and ideation in both the past month and the past week. The first part of the assessment is about going through the protective factors, which would be what is keeping Kelly from completing the act. The part goes through any attempts that were made, including self-harm, and events surrounding Kelly that would impact her decision to take her own life. The second part goes through suicidal ideation specifically and asks questions related to taking Kelly's own life and if she would have a plan, including what that plan would be as far as details go. The third part asks questions about suicidal behavior and her risk and how it can affect her. Al Lind concluded the SUAS and CSSRS were better than chance in classifying 114 suicide attempts occurring within the first 3 months, and instruments that predicted non-fatal repeated suicide attempts did not predict suicide, and vice versa. For Kelly, and having a suicidal risk, it would be fairly high, due to multiple suicide attempts. Kelly has 4 attempts over the last 10 years, with the first one happening in 2012, and the most recent one happening in 2019. The aggressive behavior has also happened 4 times over the course of those years as well. In terms of her attempts over the past 3 months, she has made no attempts. In terms of self-harm, there has been minimal damage as far as self-infliction goes. For her attempts of suicide, the injuries have been minor. The resources used for Kelly are a guide to keep self-harm behavior controlled, which has tips on coping from self-harm outreach and support. And the second resource is calling the National Suicide Prevention Lifeline. Kelly had a mental status exam conducted. The exam brought out items of hygiene state in terms of the fact that Kelly had an odor on her clothes and body odor, no makeup, no jewelry, a tattoo, and a scar on her arm. She was stuttering and slurring her speech. She was increased in her speech pattern for how fast she was speaking. She had agitation at times with outbursts and had decreased eye contact. Her behavior was normal for someone in their 20s. Mark Greener concluded the trainees experienced a number of different challenges when it came to administering the MSE, such as difficulty transitioning from theory into practice, and included differences in age, gender, and race were found to negatively impact administration. Kelly was not budging with giving much information, and she was not perceptive to having hallucinations or delusions. She had a logical thought process. She described the emotions as feeling numb and sad, and the rating would be a 3. Her affect was flat, and she was having feelings of anxiety and anger at times. For a diagnosis of PTSD to be brought to Kelly, there would be criteria met from the DSM-5. The code for the diagnosis of the DSM-5 is 309.81, parentheses F43.10, from the American Psychiatric Association. The criteria for the DSM-5 is divided into 7 letters, from A to G. The first criteria is that a trauma had been experienced involving a death, sexual violence, or injury, whether it was experienced, witnessed, and learned about. Kelly did experience 2 different traumas of molestation and a car accident. The second criteria is having symptoms of intrusion, which mean having flashbacks, disturbing memories, dreams, and reliving the event. Kelly doesn't meet this criteria because she does have flashbacks and memories of both the car accident and the molestation. The third criteria is avoiding certain items that are reminders of the trauma, such as certain places, situations, memories, thoughts, feelings, and even people that can bring back the trauma. Kelly doesn't meet this criterion because she does not like to talk about the trauma. The memories are distressing. She does not like to bring them up because being in the car, it is a reminder of the accident, and with the molestation, she does not like to speak of it with her family. The fourth criteria is having alterations that are negative, such as not trusting others, having negative thoughts about oneself, blaming a person or blaming themselves for the trauma, being in a negative emotional state, and being disinterested in activities. Also, there can be feelings of detachment and estrangement, along with the ability to feel satisfied and happy. Kelly does meet some of these first criteria, as she cannot remember important events as well as of the trauma. She blames herself a lot of the events. She tends to not remember any of the events before the trauma took place, but can remember the acts themselves. Kelly has negative feelings and does not think she can be happy. She cannot trust anyone, but does not have any distorted thoughts. Kelly has negative feelings and does not think that she can have blame in the molestation and the car accident. She does blame herself, though, for those events. She also has a lot of negative emotions and does not enjoy hanging out with her friends like she used to. She is often detached from people and can find it hard to express happiness. The last criteria is having alterations in arousal and reactivity associated with the events beginning or worsening after the event occurred, as having irritable behavior and angry outbursts, with little or no provocation that is typically expressed as physical aggression towards people and objects, having reckless or destructive behaviors, being hypervigilant, having an exaggerated startle response, having problems with concentration, and sleep disturbances. Kelly does meet some of the last criteria of having irritable behavior. She tends to have outbursts of anger at least 2 to 3 times a week. She does engage in risky behavior, such as having unprotected sex with different partners. Kelly is very hypervigilant of knowing where she is and who she is with, but she doesn't have a startle response. She can have problems concentrating in schoolwork and job duties, and she often has problems in getting customers' orders right at work and has problems with completing homework as well. She also has problems with both falling asleep, as she will fall asleep at 11 p.m., but then be up and be woken up by nightmares every couple hours. There are 3 different type specifications of a post-traumatic stress disorder diagnosis. The first is a diagnosis with dissociative symptoms. This specification means that in addition to meeting the DSM criteria, there are also responses to experiencing persistent or recurrent symptoms of either depersonalization, derealization, or delayed expression. Depersonalization is a type where there is a feeling of detachment as if the person is outside or an observer of the mental processes of their body, such as watching a dream or being in an unreality of a self or the body moving slowly. Derealization type is where there is an experience of unreality of surroundings, such as the world around the person is almost dream-like or distorted. Delayed expression happens when all the criteria is not met until at least 6 months after the event or even after the event onset of symptoms, which may be immediate. For Kelly, the type that she would have is delayed expression due to the symptoms not being present in her life up until a year ago. There are 2 diagnoses to rule out for her. The first is acute stress disorder, and there's one significant difference between ACS and PTSD, which is that time duration of Kelly's symptoms is much longer. For acute stress disorder, the symptom duration would be a few days to a few months after trauma exposure. And for Kelly, the duration of symptoms exposures did not begin until much later and more than a month. Marie-France Martin concluded the interaction between acute stress disorder and cortisol awakening response in predicting later PTSD symptoms. Having the disorder be different in the length of time that our symptoms and in meeting the other criteria of the PTSD diagnosis, then it would make more sense for the diagnosis to be PTSD. The second diagnosis is generalized anxiety disorder. Having anxiety can happen before or after a traumatic event, and there are symptoms that are part of a PTSD diagnosis that are not part of an anxiety diagnosis. The criteria for anxiety do not include symptoms of panic disorder or healthy avoidant and irritable behaviors that PTSD would have. The intrusive thoughts that happen with PTSD would happen with anxiety, but with anxiety it would happen either before or after the trauma. And also there'd be no compulsions that may be present in anxiety. The theory used in Kelly's treatment is the emotional processing theory, which talks about uncovering trepidation, then modifying the connection of the panic, plus the arrangement and the setup happening first, then the different data being programmed to change the distress system. For Kelly, it would be beneficial to see what she wants from her treatment and how she would proceed with having a say in her treatment. Kelly's first treatment goal is to sit in a car in the same position that she was in when the accident occurred and not have an anxiety attack that an accident would happen. Kelly's objectives to get to meeting that goal are talking about the accident 2 times a month, sitting in the position of the car 2 times a week when Kelly is with others, and using coping skills in her anxiety, such as deep breathing each time. The second goal is to take better self-care, and having better self-care, it can help Kelly to better deal with and manage the treatment. It can help her to feel better about herself and get out of the negative mindset and be beneficial to her mental state to help her better manage her anxiety. Kelly's first objective in meeting the goal is to first begin with setting a routine and proper hygiene, such as taking a shower 3 days out of the week, brushing teeth after waking up and before going to bed, and brushing her hair once a day. The second objective is setting aside 30 minutes to do a leisure activity for each day, which for Kelly would be drawing in her sketch pad. The third objective would be writing in a journal each night for 20 minutes, and in doing this it would help Kelly in having a tangible place to put down her thoughts about the day. The third goal is having a conversation about the molestation with the abuser of her uncle. The first objective is for her to come to terms with the trauma and be able to call herself a survivor. The second objective is for her to be more comfortable in talking about the trauma and seeing that it is okay for her to talk about the experience. The third objective is for her to talk about the trauma with family and have a little anxiety when talking about it. The fourth objective would be for her to join a support group for molestation survivors so Kelly does not feel alone. Exposure therapy would work well for Kelly. It can help her to see her trauma as an event that happened and help her to talk more openly about it. Having her start in small ways about having conversations and mentioning the trauma and being honest about how it makes her feel and understanding that it is okay to talk about it, Kelly can start to see that the trauma with the car accident and the molestation did have an effect on her. Deborah Beidel concluded that there can be decreases in anger of veterans. Using therapy and having reality be virtual may help Kelly to see the event in a space where Kelly can be safe and so she can control the event and feel secure in facing the accident and the molestation. For Kelly, using exposure therapy, it would mean getting in the car at some point in the future to discuss the possibility of recreating the scenario in her mind and returning to the memory. In doing this, Kelly can confront the trauma and be able to feel all of her emotions. Knowing how Kelly would feel in the first moments after the accident, it would be important to also be asking about how her parents felt about it as well, so that there could be a full story told about the impact of the event and how Kelly specifically feels about her parents being in an accident with her and how or whether it even had an impact on her PTSD diagnosis. For exposure therapy in terms of the molestation, it will require Kelly to be exposed to talking about the trauma and the years of abuse by her uncle. It would start in talking about the abuse in terms of what happened and getting Kelly to face the reality about the event and not deflecting from it. This would require admitting the abuse did take place and that it had a huge part in the impact of PTSD. Using self-care and support from therapy in terms of having a support group, it can help her in getting back to feeling like her old self sooner. Kelly does have barriers to treatment. Kelly does not want to be in treatment due to her schedule with work and school. Kelly does not see the factor in getting the help that she needs. Kelly does not want to have the waste of time in going over the trauma and having to relive it again because she would rather continue to avoid it. Adol Ennis concluded that males were less likely than females to be embarrassed and intend on access to services. Kelly's friends also do not see that treatment would be good for her. Her friends would see it as taken away from time they have with her and not having any benefit to her overall well-being. For Kelly, most of the time, she does not listen to her parents and will go along with what her friends are doing too. So to be in treatment, it would be a step backwards in terms of her being in therapy and allow her to see the treatment as benefit. Kelly's friends are people that come from varying backgrounds, and so for her to be with them and see different perspectives in this issue of going to therapy and not going to therapy, it shows her two different sides of what going to therapy and what not going to therapy would do for her. On the other side of that, having friends is a support system for Kelly that can help her to be a moral support when Kelly is going through a rough time and may need help with managing her emotions. It can help her to have that support when she needs it. For Kelly, it is important that she utilizes her friends as well as her support network around her that includes teachers, parents, and others, so that way she can start therapy and begin to heal from the trauma that was caused by her family. Having therapy be on campus and having her friends there as a support system, it can help her to understand and begin the road to healing and help to understand the therapeutic process as it can be a benefit to getting the treatment that she would need. There are 3 ethical standards that can be applied to Kelly's case. Having ethical guidelines to help in giving quality care that is up to the standards of the American Psychological Association, it can help to give better care to Kelly and also help her to understand how the ethical guidelines would be used in the treatment process. Rebecca Campbell concluded that the results showed stages of the research process, collection, and dissemination. The 3 standards that would be used are Standard 10.02, Standard 10.03, and Standard 10.10. The first standard that applies to Kelly's case is the APA Ethical Standard 10.02, Therapy Involving Couples or Family. Kelly would be in therapy with her family to help in talking to them about the trauma that she endured and how it impacted her. For Kelly, having her family involved in the therapy sessions, it would help her to confront and be exposed to the trauma that has been in her life, as well as give her family a chance in them looking at how the trauma affected her and how the therapy sessions would be conducted. The second standard is the APA Ethical Standard 10.03, Group Therapy. For Kelly to engage in group therapy, there are a lot of standards to look at in terms of roles and responsibilities of the group and how the group facilitator in confidentiality has privacy. Having different roles and responsibilities of having a group and facilitator that group session, it can be helpful to the psychologist to talk to the group before the session starts about the rules and responsibilities that the group members would have. Having limits of confidentiality be talked about before the group starts, it helps to make the group members feel safer in expressing their thoughts, feelings, emotions, and overall stories of trauma. The third APA ethical standard is 10.10, terminating therapy. Eventually, at some point, after a few weeks or months after Kelly would be entering treatment, there would be a point of her being discharged from therapy. For ethical guidelines to be used in terminating the therapy, it can be helpful in understanding how to terminate the session after a few weeks or months. What Kelly would need in therapy would be terminated after Kelly meets her objectives and goals and no longer is in need of the services. Having the ethical dilemma of terminating therapy for Kelly, it is more of a goal for her to do things on her own after treatment and give her the tools necessary to get through and be able to understand how the trauma had and may still have an impact on her. The recovery rate for Kelly would be slow in that she would be not up to being in treatment and understanding that Kelly would need to go out of her own way in order to see an improvement of not only her symptoms, but her overall affect and physical appearance. Having her start slowly with group and with individual therapy, it can help her in getting acclimated to the therapeutic process. And so doing the therapy with the family at a point would want to be handled in her recovery as soon as her therapy would start to repair relationships that Kelly has had with her family can be handled and dealt with accordingly. Recovering from the disorder is not something that would happen overnight, and for Kelly, the full recovery would be lifelong. Judy Hafner concluded that the effectiveness of a PTSD recovery program as an adjunctive treatment for PTSD. The prognosis for Kelly would be good if she is willing to undergo therapy and work in her skills in her healing. Then Kelly can see her progress and does not have to be regressed. Having a long-term recovery plan for Kelly, it would include items of self-care every day and helping Kelly to get to a helpful and recovering place of being in a better mental state where she is not being controlled by the trauma. Another item that would be helpful is having a conversation about her experience and using it as a positive discussion about what trauma can do to a person and being able to talk about it openly, such as talking about it in speaking forums or social media. And it can help her to not feel so alone and be in a negative headspace. What can also help with Kelly is checking in with her therapist daily and checking in with her support system on a weekly basis so that she can feel more stabilized and more in a group setting. Kelly is presenting problems related to trauma from her past with family members and trying to get her schoolwork done and her grades back up. The trauma that had been endured by Kelly was a serious car accident at age 10, where her parents had been on drugs of cocaine and alcohol, and from the ages of 10 to 12 being sexually molested by a family member, her uncle. The assessments that were conducted for the diagnosis of PTSD are the CAPS-5 PTSD checklist and PTSD symptom scale. The treatment for Kelly was determined to be exposure therapy and having Kelly be exposed to trauma slowly. The diagnosis of the disorder was met with the criteria. Having Kelly also have better self-care and have goals to meet in therapy, it was able to show her what she can do in therapy to overcome the traumatic events. Having Kelly also attend group therapy sessions, it was able to help her in not feeling feeling so alone in the trauma that she has. The ethical codes that were present in having the therapy be done were standard 10.2, 10.3, and 10.10. Kelly's prognosis would have been determined as good if she would stick to her treatment plan and was able to have therapy for herself in a way of expressing her emotions. Here is the first slide of references. Here is the second slide of references. Here is the third slide of references. And here is the fourth slide of references. Thank you for watching.